microphone is very sensitive, so just hear that. Hi, everyone. Thank you for coming. A few more people are going to kind of probably fill in, but we're going to get started. I'm just going to start with a few announcements, and then I'll introduce Dr. Goldstein. So thank you for coming, and if you haven't already, help yourself to some food. I think help yourself to a few more boxes on your way out if you want. There might be some extras. We also want to thank you for those of you who completed the VI Scholar Survey. We really appreciate that feedback and compiling the data now. Looks like about we had a 42% response rate for us, which is, I know the busy schedules, that's really says something, so thank you. One of the questions was kind of about meeting availability, and I know there's not one good time that works for everyone, but we did find that a lot of people were noting that maybe Tuesdays and Thursdays seem to work well. And speaking of which, our next Scholars session will be on a Thursday, and actually it'll be in November 10th. Megan Lanefall, who's an assistant professor of anesthesiology and critical care at University of Pennsylvania, she'll be here speaking about hands-off from the operating room to the ICU. So I'll send you a reminder email about that as well. And in October, there's actually a full schedule of innovative discovery series sessions happening, and it is Health Literacy Month, so I know that Sarah Faye had coordinated at least one of the talks on October 14th about health literacy. So keep an eye out for those reminders. All VI scholars are added to that distribution list, so you will be getting those. And what else do we have? We are currently updating the internal and external VI Scholar websites to make sure that everyone is included. We have a lot of new scholars being added on a monthly basis, so we're going to try to work out a schedule so that stays up to date on a regular basis. And if you do see any changes that are necessary, I know titles are always changing as well, so we're trying to stay up to date on that, but if there are any changes that aren't currently incorporated, just let me know. And we still have some open scholar dates, so we are booked through December. Roshni Giri will be presenting her work on palliative care in December. But starting in January, we do have openings, so if anyone's interested in speaking, I know a few of you who responded to the survey noted some potential topics and maybe some potential dates, so I will be following up with all of you on that. So keep an eye out for me to harp on you a bit. In addition to speaking at Scholars sessions, Janet Larry Prowse has the Current Issues and Research session. I know that the audience is primarily nursing staff, which is a really important venue to really kind of keep abreast on the work that's going on with them. And she was looking for speakers for those sessions. The next session is September 21st. I know that's cutting it very close, so they are also looking for speakers in 2017. So if anyone's interested, feel free to reach out to me, or you can contact Janet Larry Prowse directly. And I'll send an email out to you as well about that. So our speaker today is Dr. Jennifer Goldstein. Jennifer completed her bachelor's from Cornell University in 2002, her medical degree from Thomas Jefferson University, Sidney Kimmel Medical College, and then completed her postgraduate residency in medicine at Mount Sinai School of Medicine in New York. Following that, completed a fellowship in general internal medicine and received her Master's of Science in Health Policy and Research from the University of Pennsylvania. In addition to her clinical and professional work, Dr. Goldstein acts as an editor for several medical publications, including, but not limited to, Contemporary Clinical Trials, Annals of Internal Medicine, and the Journal of General Internal Medicine. She's also published work in many of these same venues, including JAMA, Journal of Clinical Oncology, and Journal of General Internal Medicine, as well as medical textbooks. So in addition, Dr. Goldstein's acted as chair of abstract committees for the Society of General Internal Medicine, Medicine's Mid-Atlantic Annual Meeting, and is a member of the National Physicians Alliance. So without further ado, I'll hand it over to Jennifer to kind of speak about her topic for today. Thank you.
Hi, everyone. I'm just going to have to make a correction. I'm not actually an editor of any medical journal. I'm a volunteer reviewer. But for some reason, that ended up on my profile at Christiana. So just know my credentials are not that great. So today I'm here to talk about observation status, the unintended and intended consequences of a Medicare policy. I'd first like to thank my collaborators, Dr. Hicks, Dr. Schwartz, many folks in the VI, including Zugway, Paul, Dominique, Mitch, Rick, and then Patty McGraw, Tobias Banks, and Caitlin Sternat. So what is observation policy? So observation status, when a patient comes to the hospital, they're sick, they come to Christiana, a nice doctor who looks a lot like me has to make a decision whether they're admitted as an inpatient or as an observation patient. The definition of observation status has changed over the past 20 years or so. In 1996, it was designated really for patients who were receiving care in the hospital that could adequately be provided in the outpatient setting. The classic scenario was a patient who came in with chest pain. They were ruled out for having any acute coronary syndrome, but they stayed in-house to get an echocardiogram or stress testing when they really could receive that as an outpatient. In 2009, the definition changed, and these are CMS policy changes, to a window period. It was really a gray area for patients who were in the window of a decision being made whether they were sick enough to stay in the hospital or whether they should be discharged home. That window period was expected to be approximately 24 hours, certainly no more than 48 hours. In 2013, the 2 midnight rule was implemented, and this was a policy that now stated that patients with an anticipated length of stay of less than 2 midnights should be designated as hospital outpatients, which that's observation status, and those with an anticipated length of stay greater than 2 midnights should be designated as inpatients. A key point is that this is regardless of level of acuity. So back in 1996, level of acuity really mattered. Observation patients were considered patients who were really well enough to be receiving outpatient care. Now, since the 2 midnight rule, patients could be admitted to the ICU and could be under observation status as long as they were expected to turn around relatively quickly. What's the big difference between inpatient and observation status? These patients are identical on the floor. They're treated in the same way, generally in the same medical units. The main difference is how Medicare pays for them. An inpatient is billed primarily through Medicare Part A. Part A covers their hospital care, including room, board, labs, meds, radiology, etc. It also covers 20 days of subacute rehab stay after their hospitalization. Anytime a patient's admitted under inpatient status, they have to pay a deductible. In 2016, that was $1,288, and that covers you for your care for 60 days after you're discharged. So if you're readmitted 30 days after, you don't have to pay that deductible again. You're covered. There's also a Part B fee or billing that covers physician services, and patients are required to pay a 20% copay for that. Now on to observation status. Everything is billed under Medicare Part B. It's an outpatient billing status. So you have to pay 20% of everything. That includes room and board, labs, meds, radiology, physician care, and all the rest. No one bill can exceed that inpatient deductible of $1,288, but the summation of the bill can. There's no coverage for SNF care, so patients who need subacute rehab after their observation stay would have to pay out of pocket. It's an average of greater than $10,000 per SNF stay. And the question comes up of how much do observation patients actually have to pay. They have to pay about $400 to $500 per stay. That's less than that inpatient deductible. But the issue comes when patients come back to the hospital again and again and are repeatedly admitted under observation status. So when you're an inpatient, that deductible covers you for 60 days post-discharge. When you're an observation patient, it doesn't matter how many times you come back, you're still responsible for the cost. There's no ceiling. So Shreya Kangovia Penn did a study using Medicare claims data that showed that patients who were readmitted multiple times within a 60-day period under observation status, about 26% of them ended up having to pay more than the inpatient deductible. That about a quarter of patients who were repeatedly admitted under observation status were racking up considerable costs out of pocket. what impact will the Two-Midnight Rule have on observation patients? So Anne Sheehy found that observation stays will likely increase. So the Two-Midnight Rule will actually shift inpatient admissions that were formerly inpatient to observation admissions. So the number of patients admitted under observation status will increase. And that in turn could place more beneficiaries at risk for repeat visits and higher financial liability. So the potential consequences, as I mentioned, repeat observation visits could potentially lead to uncontrolled out-of-pocket costs for patients. And our first questions really were, which patients are most susceptible to repeat observation visits? And what is the potential impact of the cost sharing on future utilization of observation status by beneficiaries? How does the cost sharing element actually impact their potential behavior down the road? And could it potentially decrease their utilization in the future? So there were 3 study aims, and these were addressed in 3 separate studies. Not the most efficient use of time, but they were relatively short studies, and I had a lot of wonderful support to do them. So our main study questions, first, among Medicare beneficiaries admitted under observation status, is low-income status associated with a higher risk for repeat observation visits? Second, is there an unmet need for SNF? And could this be associated with repeat visits or hospital revisit in general? Third, could beneficiary understanding of observation policy reduce utilization of observation care by them in the future? So let's talk about our first study aim. Prior research has found that poor access to primary care leads to increased hospital utilization. This is particularly pronounced among patients who reside in low-income areas. My hypothesis was that patients who resided in low-income areas without good access to primary care could use the hospital more, as been shown in previous studies, and could be admitted under observation status more. This could become a cycle, and they would incur excess costs. To examine this question, we merged a CMS claims data, so this is Medicare claims data, with U.S. Census county-level poverty data. We merged on county code, and we looked for patients that had at least one observation stay. We then divided up the patients into what we called poverty quartiles, and this was based on the poverty data that we obtained from the U.S. Census. Each patient was placed in a category from quartiles from low poverty to high poverty. And then we also pulled out the patients who resided in the poorest counties, poorest 3% of the counties, and the wealthiest 3% of the counties. What we wanted to see was whether between these quartiles and groups, whether the number of observation visits was different, whether the average out-of-pocket annual cost related to observation care was different, and what the ratio was of out-of-pocket cost to average annual income, really trying to assess the burden of the cost on each of these patients, or categories of patient. So out of 54 million claims, and Zue can attest to this, I think it takes 8 hours to load up the CMS data on his computer. There were 132,000 observation stays representing 67,000 unique beneficiaries. Is that still up there? Didn't do anything.
There we go.
Oh, okay, perfect. Median income estimate was about $49,000. The median income estimate in the poorest 3% of the counties was $30,000. That's about twice the federal poverty line. And in the wealthiest was about $84,000. What we ended up finding was that, so is that good, perfect. These are the poverty quartiles. This is low poverty going up to high poverty. That's the fourth quartile. And these are our poverty extremes, the wealthiest 3% of the counties and the poorest 3% of the counties. We found that as you went up in terms of low poverty to high poverty, there were a higher proportion of patients had greater than 3 observation stays. We found that the mean and median cumulative costs, they were statistically different between the highest poverty and lowest poverty, but they didn't look meaningfully different, and the number was actually lower for the highest poverty. didn't make a whole lot of sense, but we thought that this could potentially be attributable to aid programs that are available for high poverty patients in Medicare to help supplement some of the cost burden. What we did find, however, is that in our extremes, so among our wealthiest compared to our poorest patients residing in the wealthiest versus poorest counties, we found that about 5% of patients who were in the poorest counties had greater than 3 observation stays, compared to 2.29% of patients in the wealthiest counties. And we found that their mean cumulative costs were significantly different, with a much significantly higher amount of money spent in the poorest counties, and also a much more significant cost burden. So we found that 1.51% of the mean annual income of patients in the poorest counties was spent on observation care alone, and that was compared to 0.58% in the wealthiest counties. So our conclusions, so these were unadjusted numbers, by the way, and we're still, we need to adjust for level of illness, acuity, and a number of other factors. But our preliminary results found that Medicare beneficiaries who reside in high poverty regions had higher utilization of observation care, and those in the highest poverty areas may sustain higher financial liability and higher cost burden compared to those in low poverty areas. Second study aim. Is there an unmet need for SNF, and could this be associated with repeat visits? So this question was really based on my personal introduction to observation care. I was a new hospitalist 2 years ago, and I had no idea what observation policy even was. I had a patient who was 83 years old. She was admitted with a compression fracture of her thoracic vertebrae, and she was admitted under observation status for pain management. She didn't meet inpatient criteria. We were trying to get her home. She lived in a house that had 6 steps going up. Her family lived far away, and because she was admitted under observation, she didn't qualify for subacute rehab. We tried really hard to get her somewhere else, but she had to go home, and she came back the next day, again, under observation status. So when I started reading about this issue, one of the first papers I read was this study, The Origin and Disposition of Medicare Observation Stays. This was an analysis of Medicare data, and what they found was that only 0.75% of patients who were admitted under observation status were discharged to a subacute rehab. And what they took away from that is that very, very, very few Medicare patients are at risk for the high out-of-pocket costs associated with SNF care. They said the policy works. Nobody's going to SNF, so that's fine. And in my mind, I thought that was crazy, because plenty of people would go, but they just can't because they can't afford it. So I wanted to do a study to just prove to myself that this was an issue, and hopefully to you all as well. But the hypothesis here is that people are admitted under observation status, and they end up going home because they can't afford SNF. They come back, perhaps several times, until they're ultimately admitted as an inpatient. They're sick enough to get inpatient status, and then the world of SNF opens up, and they are allowed to go where they should have gone in the first place. So our methods here, this was a retrospective observational study of Medicare beneficiaries admitted under observation status here to ChristianaCare within the calendar year 2013. We obtained the data from our EMR and administrative databases. We limited patients to our hospitalist service. That represents about 80% of observation patients nationally are taken care of on hospital floors by hospitalists. We wanted to limit our selection to patients admitted from home. They were excluded if they were admitted from any facility to the hospital, because those folks will have a higher probability of going back, right? But we also excluded patients who were discharged to non-SNF facilities. We didn't look at them. And there were some administrative errors that we tried to account for if Medicare had been erroneously listed as their primary, or if the patient had a prior inpatient admission, so within that 60-day time period, that actually qualified them for SNF stay. So we had our observation admissions in 2013. We examined this cohort of patients. We looked at demographics, admission diagnosis, length of stay, disposition, and 30-day hospital revisit rates. That was for the total cohort. Then we did a chart review on 30% of that group, and we looked at case management notes and the physical therapy evaluations. If they had a physical therapy evaluation, we looked at what the recommendation actually was, whether they were recommended for home without services, home with physical therapy, possible SNF, or SNF. And for this group, we looked at disposition, length of stay, and 30-day hospital revisit. The point here was to really see how many people really needed SNF within this cohort and where they actually went and what their outcomes were. So we had 1417 observation admissions. 94 were ultimately excluded for a number of reasons, which left 386. 181 of those had physical therapy evaluations. I'm sorry, I keep using this cursor and I don't need to. And we found that about 30% had no further needs. 35 were recommended for home physical therapy, 11 were recommended for possible SNF, and 17 were recommended for SNF. Further in our results, the column is the discharge disposition, and then at the bottom we have the adjusted length of stay and also 30-day hospital revisit. And a 30-day hospital revisit accounts for combined emergency room observation, revisit, and inpatient hospitalization. And then we have our physical therapy recommendation on the columns. So for our total cohort, our total sample of patients, oh, did I mess that up? Yeah, okay. Oh, no, I'm good. So we found that 0.83% of our total cohort of observation patients went to SNF. That was pretty consistent with what Fang's group found, that 0.75% of home-dwelling Medicare patients went to SNF. So we found their length of stay was about 46 hours, 47 hours. 30-day hospital revisit rate for the total cohort was 24.3%. Now looking at the patients who had physical therapy recommendations, we found that 17 were recommended for SNF, and only 1 went to SNF out of that group. Their length of stay was significantly longer if they had a recommendation for SNF compared to home with no services. And also their revisit rate was significantly higher at 52.9% compared to 25.4%. So conclusions from this study is that there does seem to be an unmet need for SNF among observation patients. The revisit rate appears to be higher for those recommended for SNF, and length of stay also appears to be higher. So my gut instinct, as well as every other hospitalist gut instinct, was correct, at least within the limitations of this study.
But do you know of those data in patients who are inpatients? So you could make an argument that those same things hold true for people who are inpatient and don't end up in SNF after discharge.
That could be true, but they are covered for SNF, whereas these people are not. And we can't. We also did a little bit. We did review the case management notes for all of the patients who were recommended for SNF to see if we could get any data about how they or their family felt about going, because some of this is patient preference. A lot of people just don't want to go, and I get that. But we found that the majority of people that were recommended to go did want to go. They would have accepted it if it had been available. But there were also a handful of people who would not have gone or their family refused. So our third study aim, could beneficiary understanding of observation policies or costs reduce utilization of observation in the future? So this concept might be a little less obvious, but within the context of prior work might become a little bit more clear. Prior work has shown that cost sharing decreases utilization of certain health services, and this effect is particularly pronounced among low-income patients. So Trivedi has done a lot of work in this area and found that increased ambulatory care co-payments leads to reduction in ambulatory care use and increased hospital use subsequently. they found a similar effect with cost sharing for screening mammography among Medicare patients, particularly pronounced among low-income beneficiaries, that cost sharing reduced the utilization of mammography. So compounded with this, another interesting development in the observation story is that in August of 2016, the Notice Act was signed into law. And this was the result of several very high-profile legal cases where patients had racked up excessive costs for observation care and were completely unaware that they were in this status. So Medicare, this Notice Act was signed into law, which requires that all Medicare observation patients be made aware of their status and the implications of that status within 72 hours of their admission. They have to sign a form, so they have to be informed, and they actually have to sign their initials on the form stating that they understand the policy.
What's their alternative?
What's that?
Even if they understand the policy, can they say, I want to be inpatient?
Yeah, it's complicated. So my understanding is that you cannot appeal an observation stay. Anyone care to comment on that? But that is my understanding.
Frequently will actually say I'm being inpatient. And it's incumbent upon, it actually does have to be the supervising provider who has to appropriately document whether or not the patient should be inpatient. And if you can't do that, then they fall under observation. That's it, regardless of what the patient wants.
It's a nasty one, this policy. No, it's difficult because patients don't, I don't know, so just wait for it. Patients don't have many options. So let's talk about the potential impact of that, because that's what I was particularly concerned about. So here is what I call the fear of seeking additional care. It's a scenario where a patient is going back and forth to the hospital, admitted under observation, they're racking up costs, and then they stop going back because they don't want to go anymore. So to examine this question, we did a prospective, it was really a pilot study, it was a small study of a cohort of Medicare beneficiaries admitted to the general medicine service under observation status to Christiana. We did it for about 5 months because that was the amount of support that we had. We excluded patients for a number of reasons: if they were younger than 18, if they were admitted to the ICU or step down, direct admissions from home, transfers from other services, on the teaching service, limited to comfort care or as confidential patients. We wanted to try and keep this as homogeneous as possible. So our methods were, we had our cohort of Medicare patients admitted under observation status, and we administered a survey. The survey was a 23-item survey administered at the bedside. It was an interview survey. First couple of questions addressed whether they understood the billing policies related to observation care. And these were quiz type questions. They were true-false questions. There was a question about whether they were concerned about their bill, about having to pay for their current stay. There were a number of questions about whether they rationed health services over the previous 12 months, and these were taken directly from the National Health Interview Survey. It was related to prescriptions and also health services. And then the last couple of questions, before asking these questions, we told them what the answers were to the first couple of questions. So we informed them what the true policies were related to Medicare observation. And we asked, well, if you were admitted under observation status, again, would you ask, first of all, would you ask about your status? Second of all, would you stay for the care? Or would you consider requesting outpatient workup? Or would you even consider leaving against medical advice? We also recorded income, age, sex, race, and we ended up, and we looked at the results, we dichotomized the results by income level, either above or below the federal poverty line, assuming that there could be an impact differentially among lower or higher income patients based on the prior work that had been done that showed that the effect was stronger or the effect was greater among low-income populations when it came to cost-sharing issues.
Jen, 2 questions on your methods. One, how did you get the income?
Income was self-reported, and we only gave them two options. So we gave them below or above. We
Okay.
said below 31,000 or above 31,000.
Did you
Yeah.
get, I'm sorry.
My other question was, why exclude teaching patients?
I don't know. I don't know why. When I read it over, I don't know why.
It's a survey. Administration.
Oh, but also the teaching service can't admit observation patients. There were limitations on that. That's why.
Gotcha. Okay, so that's a different.
Yeah. They do sometimes, but I think that was our reasoning at that time.
Did
Okay.
everyone answer all the questions, or did you have people?
No, we had people who refused, and I think I listed, at least for the table that I have, refusals. Income is one of them. So, all right, so we had 466 eligible patients. We received a list every day of observation patients that had been admitted within the 24 hours prior. So we tried to interview patients within the first 24 hours of their admission, and we received lists at 5 in the morning every day. We ended up increasing that to twice daily lists, so 5 a.m. and 1 p.m. to try and capture more. There were, but all the data was collected during daytime hours and during weekdays. So there were 466 eligible patients, 160 ultimately completed the survey, and 144 were included in the final analysis. So these are some of the more interesting results that we found. We found that patients who were lower income were more concerned about paying for their observation stay. And we also found that patients, if they were admitted under observation status in the future, lower income patients most patients were willing to stay for their care. But lower income patients were more likely to request services arranged as an outpatient and were more likely to leave AMA. The numbers were really low. They weren't statistically significant, but there was a trend, and we were really underpowered to show any statistically significant difference between these groups. But we were concerned and interested in the trend. So in conclusion, we found that low-income Medicare beneficiaries are likely more concerned about their hospital bill, and they may be more likely to consider leaving the hospital if admitted under observation status again in the future. So back to our main concerns that kind of drove these study questions. We're concerned about repeat visits leading to uncontrolled out-of-pocket costs, and we wanted to know which patients were most susceptible to repeat visits and high cost burden. We found that low-income patients and those in need of SNF could be more susceptible to these repeated costs and higher cost burden. The question of whether current observation policies had a differential impact or could have a differential impact on vulnerable populations. We found that it could potentially have a differential impact on low-income patients because they ended up having a higher number of visits and higher burden on their annual income, and also debilitated patients because they had a barrier imposed on their needs. The two-midnight rule is likely going to increase observation admissions overall. So concerns moving forward are that low-income patients may be at higher risk for observation utilization and burden. Those that are in need of SNF may not get the care that they need and have higher rates of hospital revisit, longer length of stay, and subsequent out-of-pocket costs. And that cost concerns related to observation care may ultimately lead beneficiaries, particularly those who are low income, to think twice about staying in the hospital for observation care in the future. Future direction, so research, more research needs to be done, larger scale studies need to be done to really determine the impact of this policy on medical decision making for patients and also on outcomes. Hospital system, there have been several important efforts here at Christiana to standardize observation care to limit length of stay. So we have our MOU, which is in full swing at this point, and one of the driving forces behind medical observation units is using standardized practices to try and limit the number of tests that are done and limit the length of stay. All of that will help the patient's pocketbook, and it will also help us with throughput as an institution. As an institution, we can also try to decrease barriers to early discharge from both the medical units and also from the emergency room. There have been several efforts to reduce unnecessary admissions and readmissions. We feel that particularly now that we have an ACO, and we've been trying to use resources like CareLink to help support us in those endeavors. Regarding policy, CMS is currently standing firm on their 2 midnight rule policy, but there are several professional organizations and advocacy organizations that are actively fighting the policy, including the Society of Hospital Medicine. So that is all I have.
I have one question and one comment. Maybe you said this earlier, I was a few minutes late, but what is the stated purpose of the rule from CMS? Are they hoping that people will use these costs to make different decisions and say, well, I don't want to stay because it's too expensive? Is that the goal? Or is the goal something else from a policy point of view?
The goal, so policy from my reading, the policies really seem to be driven by the insane costs that Medicare has to deal with. They pay a lot of money and have paid a lot of money for what they call unnecessary inpatient admissions. And they introduced several measures to try and reduce those inappropriate inpatient admissions. And changing these policies is one of the efforts that they've basically tried to make to reduce their burden of inpatient admissions.
So the hope is that people would say, no, I won't come in because this is unnecessary and it costs too much. And your study kind of shows that doesn't work because they said they'd come in anyway.
I'm not sure that that's certainly not been an explicit goal that's been stated by CMS. So I don't think they would ever say or admit to the fact that they don't want people to come to the hospital. But they have made it harder for hospitals to deal with those admissions because we are subjected to penalties, and they've kind of placed that burden on us as healthcare institutions to limit the number of inappropriate inpatient admissions. So they might not say it, but they're making us say it to patients that we have to make changes so that we're not penalized for inappropriate admissions.
Like one other is with the income stuff. I think you might need more granularity in terms of lower and higher rather than just the two.
I agree.
My experience is just anecdotally is there's a level of poverty below which it doesn't matter, and I've had patients who can't get any service outside the hospital, or but they're not at all worried about anything from the hospital. And I think it's just because when you don't have any money, no one can make you pay it, so you're fine. And then there's probably some level where you're high enough that you're okay paying for it. And then there's the middle. So more granularity might help find like a bell curve, like a bimodal type distribution.
I agree with you, and it was borne out also in some of the comments from our patients that a lot of patients just really didn't care. Most didn't. Most were not concerned about the cost of their bill or the price of their bill or stay.
Just can I comment on the observation? So what Medicare has done, so what they say explicitly is that for many, many years, hospitals get paid by the volume of patients that they see. And what they noted is the cost went up. They saw a fairly substantial proportion of patients being discharged within 24 to 48 hours for whom they were paying these very large bills. And so the impetus behind observation status, as they sent reviewers out and began to look at these charts, was to say there are many conditions where the most frequent presentation of these conditions require only that a patient not be safe to go home immediately from the emergency room, but not require the intensity of services of their typical hospitalization. So for that group of patients, and it became overly complex, we will pay you at a reduced rate, and we will pay you for up to 48 hours of care, and that's it. So it's really the intent of the law is really to make healthcare facilities not hospitalized patients and bill for them as if we're providing care for a higher level of intensity in terms of their disease, when they simply require observation and stabilization for the short term. And they've largely enforced this by imposing penalties and making people pay. So I was just looking it up at a hospital in Boston, ended up in 2013 having to pay $5.3 million back to Medicare after they reviewed a number of charts and found out they were billing for inpatient stays, and these were commonly, it's a very prestigious hospital, commonly these were conditions that most people would bring in syncope, right? Yeah, under observation status, and we're billing inpatient status. So that was really the intent. The unfortunate consequence has been the patient side of things.
I just had a question about or comment about your A1. I mean, I was impressed that you found that correlation, given that it's probably diluted a little because county is not a very sensitive. I mean, just look at Newcastle County. You have very high poverty areas, and then you have Greenville. So that kind of all averages out. Whereas I'm assuming you didn't have access to anything more concrete like zip code or census. Yeah. So that, I mean, certainly I think you'd see an even greater effect if you could get more discrete data like that. And then also, was there any way that you can adjust for co-insurance? Because certainly, like the most poverty, they're going to have Medicaid as well, which is going to kind of get rid of all those costs.
Yeah.
The higher incomes will have Medigap policies.
Yeah, exactly. So that's one of the reasons why we looked at those extreme values, so the top and lower 3%, because we didn't find fantastic discrimination between the poverty quartiles. Even the mean income between each of those quartiles was not dramatically different. So that's why we pulled out those extremes. And we could not, with this, I got the cheapest data set I could. It was $1,000. And it's the limited data set, very limited information, and it did not list the code for dual eligibles. So we were not able to pull that out.
But is there a differential impact on cost of the patient based on whether or not you have Medicaid as a co-insured? It's one of the questions that we should ask. That's sort of a response to that, right?
If Medicaid is, so these are for Medicare primary patients. So if Medicaid is primary, they're not going to get billed at all, right? For observation.
Right. I'm not sure about that. We'd have to look.
I don't think they are, because I've addressed this on the floor, and they don't receive that 20% copayment under Medicaid. So these are still Medicare primary. I don't know how Medicaid works as a secondary with picking up.
It's a secondary. It's more for long-term care, not for
Okay.
acute hospitalization. So if it's secondary for acute hospitalization, it's Medicare because it's long-term Medicaid. I think is the secondary, right?
I thought Medicare was never the primary if there was any other insurance.
I think I'm 100% sure that if you have long-term Medicaid, Medicare is your primary insurer for hospitalization. I don't know about but we should check.
So are you, with the new policy changes, like the Notice Act, are you planning on kind of taking a look at that and see if that, in terms of like medical decision making, that's having any effect on this population?
I think it's an interesting question. So all of the patients that we surveyed for our interview survey, all of our study started after Notice was put into place. So we started the same month that Notice was put into place. So on top of us interviewing the patients were also receiving case management discussions, and they were also receiving a pamphlet that we had created from Christiana. The thing about the Notice policy is that the policy states that the patients have to be made aware within 72 hours. You can understand why. Mostly it's case managers that do that work. They don't work 24 hours a day, 7 days a week. So if a patient's admitted on a Friday, they still have until Monday to officially notify them. But patients are often discharged prior to 72 hours. And so it is somewhat flawed. But my interest in the question was in part driven by the fact that understanding this policy, the understanding of this policy overall is going to increase because now they are required to be notified. And there's been a little bit more publicity. And so my concern was that as people are made more aware of this, will they become more concerned about it? Will that impact their decision making moving forward?
Also, in terms of how it's conveyed, is there standardization or is there variability in terms of how it's being presented? Like in terms of, is there potential for patients, if it's not as standardized about how it's introduced to them, is there variability in their level of understanding?
And CMS is trying to address that also, the more standardized form. I think it's called the MOON, MOON. So they're reworking this. This is a very much a moving target. They're receiving a lot of pushback from many different patient advocacy organizations and medical organizations based on these rules that they keep changing as they move along. But the objective is to try and, most recent objective is to try and get a more standardized version, simpler version of that Notice Act out.
Thank you, Jennifer. Or is there a question?
Dr. Hicks?
Sorry.
Because Jennifer won't brag about herself, so I just want to brag about her.
Please.
So all three of these studies that she talked about, she drove and conducted sort of simultaneously while being a busy hospitalist, all within 6 to 8 months, with a ton of support from several people who are in the room, but has been extraordinarily productive. One of the papers was submitted and they asked for a revision. She's revised it and it's now under review already. The other one is a brief report ready to go out, and the third needs the the next step of adjustment. And the comments here are actually very helpful in thinking about writing up that paper. So I think she deserves a ton of credit.
Fine.